Well, good afternoon, and thank you for joining us for today's listening session on health insurance issues for people with disabilities. My name is Kathleen Borain, and I serve as the Maryland Insurance Commissioner. My co-host today is Maryland Department of Disability Secretary Carol Beatty. Welcome, Secretary Beatty. Just a few logistics as we get started. First, in addition to our ASL live interpreters, we are offering closed captioning for today's session. To access the closed captioning, go to the bottom of your screen, and on the right side, you'll see the word More with 3 dots above it. Click on those dots and choose the closed caption option. If you have any questions or concerns about how to do that, just provide a note in the chat room and we'll have somebody help you. Second, the listening session is being recorded and is being live streamed on Facebook. To help ensure excellent sound quality throughout the session, we ask that you please stay on mute unless you're speaking. So with that, again, welcome and thank you for joining us. Throughout 2021, the Maryland Insurance Administration has been holding listening sessions to help us more fully understand the needs and concerns of specific communities with respect to insurance. These listening sessions assist us in fulfilling our statutory mission to oversee the business of insurance in the state. These sessions enable us to identify gaps and issues that need to be addressed from an enforcement or educational perspective, and they provide valuable insights that inform not only our work, but the work of other state agencies. What we learn from these sessions helps us also to be more effective assistance to policymakers, including the members of the General Assembly. Our previous sessions include healthcare insurance needs and challenges for women and their dependents, the role of insurance in addressing healthcare inequities, financial security insurance issues for the LGBTQ+ community, and insurance considerations for rural Marylanders. To see videos and presentations from our previous sessions, please visit the Maryland Insurance Administration website at insurance.maryland.gov and click on listening sessions in the right-hand column of our homepage. Today, our focus is on insurance issues and concerns for Marylanders with disabilities. First, let me introduce you to the Maryland Insurance Administration staff who are on the call with us today. So first, let me introduce Corey Boone, my Chief of Staff.
Good afternoon.
Joy Hatchett, the Associate Commissioner for Consumer Education and Advocacy.
Good afternoon.
David Cooney, the Associate Commissioner for Life and Health.
Hello, everyone.
Craig I, our Director of Communications.
Hello and welcome.
And Victoria Laird, our Communications Specialist.
Good afternoon.
We have a number of invited speakers and members of the community that we will hear from today. After hearing from Secretary Beatty and our invited speakers, I will call on those who registered to speak first. If you did not register to speak, we still want to hear from you. So please use the chat feature to say that you would like to speak. As time and technology allow, we will bring you into the panelist area so that we can hear your comments. And now to kick us off, we will hear from Secretary Beatty and from Kristen Robb McGrath, the Director of Health and Behavioral Health Policy for the Department of Disabilities. Welcome, Carol.
Thank you so much. Thank you, Commissioner, for having me and our department be represented here and be a part of this listening session, which is on a very important topic. So just to lay the groundwork here a little bit, according to the CDC, there are more than 1 million Marylanders with a disability. That's about 22% of our state's population. And to add to that, the Kennedy Krieger Institute's Community Health Needs Assessment Report found that 19.2% of Maryland children under the age of 18 have a special health care need. Almost everyone is likely to experience a disability, either permanent or temporary, at some point during their lifetime. The Maryland Department of Health found that Maryland adults with disabilities report higher rates of co-occurring conditions like depressive disorders, arthritis, asthma, kidney disease, cancer, diabetes, high blood pressure, and cardiovascular disease. To address the needs of people with disabilities, the Maryland Department of Health's Disability Health Inclusion Program recommends public health staff, medical professionals, and others who work with people with disabilities recognize that this population is an at-risk priority population for wellness promotion initiatives. The program recommends taking the following steps to support the health of people with disabilities. So we need to include people with disabilities in the design, implementation, and evaluation of programs created to assist them to access and benefit from healthcare and wellness services. Kind of a good start, I would think. Use data to identify and address secondary and comorbid conditions that are most significantly impacting people with disabilities. Include standard disability indicators in public health surveillance systems. Use disability status as a demographic in data analysis and reporting. Promote active lifestyles through inclusive policies and accessible recreational sites. And develop communication plans to ensure that accessible options are communicated to people and for people with disabilities. And finally, recognize that people with disabilities are disproportionately affected by social determinants of health, including low income, less than high school education, and unemployment. Our department supports all of these initiatives, and we work with the Maryland Department of Health and other state agencies to implement these important steps. Many of these initiatives are included as part of the Maryland State Disability Plan. The State Disability Plan includes 5 guiding principles, including the newly added Health and Wellness Guiding Principle. The plan is revised every 4 years and was recently approved and released by Governor Hogan this past July. And it can be found on our website at www.mdod.maryland.gov. The Health and Wellness Guiding Principle was added in this edition as a result of the COVID-19 pandemic, because we've seen that people with disabilities were and continue to be disproportionately affected during the pandemic. They are at an increased risk for contracting COVID, developing severe symptoms, or even dying from COVID, as well as having poor health outcomes during or after their exposure. But beyond COVID, we felt it was important to prioritize these issues because people with disabilities experience many barriers to care. These barriers include cost and limited availability of services, personal care workforce shortages, accessibility, both physical and communication barriers, and inadequate skills and knowledge of healthcare workers. And also, people with disabilities also experience attitudinal, policy, social, and transportation barriers to accessing better healthcare services. The pandemic has highlighted what many of us already knew, that health disparities for people with disabilities exist. While we've made progress, there is much more work to be done. We look forward to the work of the newly formed Maryland Commission on Health Equity. The commission was created during the 2021 legislative session and became active on October 1st, 2021. MDOD was named as a member of the commission and will be represented by our Health and Behavioral Health Policy Director, Kirsten Robb McGrath. And I'd like to introduce Kirsten, who is joining me here this afternoon. Thank you for being here, Kirsten. This listening session, the commission and other efforts are all working to increase awareness of disability issues, improve accessibility, and promote the inclusion of disability as a component in health policies and programs. Thank you again to Commissioner Borain and the Maryland Insurance Administration for putting together today's listening session. And I'll stop talking now so I can hear from our stellar panelists and from all of you about your experiences with health insurance.
Thank you, Secretary Beatty, for those introductory remarks. We agree with you so much that the work of the commission will be so important, and hopefully as we put together and we continue these listening sessions, it will be a place for us to gather more data to bring to the commission for study. So thank you. We do have a number of other invited speakers, scheduled speakers today. And let me start with Kelby Brick, who is the director of the Governor's Coordinating Offices, the Office of the Deaf and Hard of Hearing. So Mr. Brick, very happy to have you with us today.
Hello. Thank you, everyone. Thank you for inviting me to be here this afternoon. Let me just make sure that we're spotlighted. First of all, thank you, Commissioner, so much for hosting this event. And thank you, Secretary Beatty, for a great opening set of remarks. I think it is mission critical that we continue to move forward and make progress in improving healthcare services and access for the disability community, including deaf and hard of hearing constituents in the state of Maryland. Now, I do want to mention briefly a few different issues very quickly, areas that we are encouraging people to get involved in when it comes to insurance and things that we're looking at. And this is based on information and complaints that our offices field. To reintroduce myself, I am Kelby Brick, Director of the Governor's Office for the Deaf and Hard of Hearing. And what our office has, first of all, actually, before I move forward with some of that, I think an important principle as we move forward in this discussion, when it comes to healthcare and for healthcare to be successful, it must have effective communication between patient and provider. That is mission critical. Without effective communication between those two parties, then ultimately, misdiagnoses often happen, misinformation is communicated, and that can result in serious healthcare outcomes that impact insurance ultimately, because research has shown that when ineffective health services take place, the patient also has to return for multiple visits time and time again, which increases insurance costs. If a person has effective communication from the onset of their treatment, they're able to resolve those healthcare needs earlier, which decreases the need for repeated visits and keeps costs in check. Now, one area I'd like to point out specifically is that very often the deaf and hard of hearing community is frustrated about their need for communication access. For example, interpreting services or live caption services. Doctors oftentimes don't know how to access those services and provide them, even though there are a variety of laws and statutes set in place over 30 years ago, as I'm sure you all know. People still have to fight on a day-to-day basis to get access to just their most basic appointments. If you call to make an appointment, oftentimes there are concerns because they have to argue and push and teach that provider just about the basics of effective communication access. Again, that's access such as an interpreter or such as captioning. Insurance can step in. Insurance has the ability to do things like, for example, mandate, unless a person has committed full guaranteed access, they won't get reimbursed for that particular appointment. Another possibility is they can put pressure, because insurance companies do want, of course, their members, the people who are receiving services via that insurance company, to get the appropriate health care and the appropriate services to be able to heal. That's not happening, as I said, if effective communication is not there from the onset. So I think insurance companies could take steps to set up structures and put things in place to make sure that healthcare providers follow the current laws that we have on the books. And if they don't do so when it comes to providing access, they might not get reimbursed. Now, second area of concern, things that we often hear from our constituents, are adults, people over the age of 18, that need hearing aids, which is not covered by their insurance provider. We were very successful, part of our office. We were involved in passing a law that expanded hearing aid access from children from the ages of 18 to now 21. We also were successful in changing the Medicaid rules that are on the books to cover hearing aids for all people from birth to end of life. So that hearing aid coverage unfortunately only applies to Medicaid, however. So there are many other health insurance companies that do not include hearing aid provisions for adults. And those adults, those deaf and hard of hearing adults, are the largest population in the disability community. There are more people with some level of hearing loss who are coded as deaf and hard of hearing than any other group. And oftentimes they need things like amplification that's provided through hearing aids. So we need to expand insurance coverage for all companies to make sure they provide that to adults. This impacts not only the healthcare field, but it impacts employment, it impacts social interactions with family, particularly for those folks who lose their hearing later in life, who do not have another language modality that they can rely on, and they really need that amplification to continue to maintain the access that they've always known. The third challenge that we often see and that we often get calls in our office about is individuals who want to receive services from a deaf and hard of hearing healthcare provider, a deaf doctor, for example, a deaf therapist, a deaf mental health service provider, so forth and so on. There's a lot of data out there that shows empirically that providers need to have what we call cultural and linguistic competence in order to best serve their constituents. Okay, cultural and linguistic competence. I think that's an important term to be aware of. And research has shown empirically that healthcare providers that have those cultural and linguistic competencies and those skills provide better care, which results in better patient outcomes. And unfortunately, when it comes to the deaf and hard of hearing population, there are not that many providers that are readily available. And there's a variety of reasons for that. Oftentimes, they're not in that specific insurance company's network of that particular individual. And patients are often struggling to convince their insurance providers to cover those appropriate professionals who might be out of network, but who can provide that specific skill set. Insurance often say things like, oh, we will provide an interpreter for an in-network provider, but an interpreter doesn't replace that necessary cultural and linguistic competence, that direct communication that can happen with a provider that is the same as the patient that they have that relationship with, be it a doctor, be it a dentist, whomever. So asking those insurance companies to cover health services outside of network for those providers who have those specific nuanced skill sets, if they don't have anybody within network who they can prove has that necessary cultural and linguistic competencies. Now, thirdly, oftentimes insurance companies send out information to their membership on health and wellness, how to take care of themselves, different proactive and prophylactic measures they can take to protect themselves. Oftentimes that information itself is not accessible. It's not captioned, it's in videos that are not in sign language. And we need to make sure that all information that's disseminated to the membership is either captioned for videos, and for everything else, be it print, be it any other type of information that's sent out, is available in American Sign Language as well for the deaf and hard of hearing community. I think with that information, that important information that people receive from insurance companies, not only is it difficult to navigate that when you don't have access, it's difficult to navigate just the nuances of the insurance application process itself. I think the bigger point here, especially during the pandemic, is we have seen a huge transition in traditional services to a more telehealth format. Now, the problem is oftentimes that transition to telehealth is at the discretion of the doctor or the service provider. And oftentimes, if there is no telehealth service option, people miss out on health service, which is really important for them to have access to. 1/4 of all the households in the state of Maryland do not have broadband internet service, according to our statistics. A high percentage of that 1/4 are people with disabilities. They are 25% less likely to have laptop or computer or device access as well. So we are talking about insurance providing health access to folks with disabilities. And we know that people with disabilities disproportionately are on the wrong side of what we call the digital divide. And a higher percentage of those folks are often people who have other marginalized identities like African Americans, the Latinx community, so forth and so on. So as we move to a more telehealth digital environment, we are leaving behind a whole population of people who don't have internet access, who don't have high-speed broadband, and who therefore are being left behind from being able to access these mission-critical telehealth services. So this is another area of concern that we are looking at in terms of how to make sure that we are providing health services in person as well as online, and that both formats are accessible so that we don't leave anybody behind who might not have that broadband access, because there are still so many people. I know there are many of us who are using the internet for work. We are privileged in that we have that type of access, but we need to remember 1/4 of households, not individuals, but households in Maryland don't have that same type of access. So that's another area that my office is looking at. So again, thank you, Commissioner Burton, for your time. Thank you again, Secretary Beatty, for inviting us here today.
Thank you very much, Mr. Brick. Very informative. One question that I do have for you is that in those circumstances where telehealth is a viable option for someone who is hearing impaired or hard of hearing, is that more helpful in terms of facilitating communication? Or, do you find that it's easier, say, for a practice to work with closed captioning in order to facilitate communication, the ability to type into a chat feature? Is there anything about the telehealth that can make it, can help bridge and be frankly, a gap measure if in-person services are not available?
When we're talking about telehealth for the deaf and hard of hearing population, the appropriate term is deaf and hard of hearing, not hearing impaired, just food for thought. But for the deaf and hard of hearing population, the issue is not necessarily whether the doctor's office can bring in a sign language interpreter or captions for remote services. That's not the initial barrier. It allows people to access, and the doctor directly. And to be fair, there are other challenges when it comes to having services done from a remote standpoint when it comes to accessibility. And that's a topic for another time. But the initial issue is that many doctors' offices are requiring the patients to receive services through telehealth without giving them an in-person option, meaning those people stay home and they receive medical services via video, much as we're doing now. But that is inequitable to those people who don't have access to internet services at home. So that is our biggest area of concern, is just the folks who don't have access initially. Beyond that, then we can talk about communication access through a remote environment. In person, there is the opportunity for them to get that communication access that they might not get remotely, particularly if they don't have that broadband service.
No, I appreciate that. And thank you for the education about the proper terminology. I do sincerely appreciate that. As many people know, the MIA is doing a very deep dive on how telehealth ought to be considered in looking at network adequacy. And we're having many conversations about what network adequacy means. And so I share with you the concern about access in the first instance and as an initial barrier for a number of groups of people who just don't have access to broadband and to the right equipment in order to make a telehealth visit work, and the need to have in-person options. So we're on the same page with respect to that. But once you are over that barrier, what I may follow up on with you is looking at whether or not, as we consider and think about what is adequacy and where telehealth can fit in, that we need to look more particularly at certain groups of people like the deaf and hard of hearing, for whom telehealth may not be as much of an alternative option for other reasons. So that may be something to follow up with you on.
Thank you, Commissioner. And I do want you to know, okay, at this point, I will turn off my screen and, for example, if anybody who is speaking, I'd like to ask anybody who is not on screen to turn off their video. The reason being is because it frees up screen real estate for our interpreter. So if you're not speaking, I'm going to be turning off my video just to set an example to make sure that we have the largest possible screen for access. And that doesn't mean I'm not here. I'm certainly staying online, but I just want to let everybody know.
Thank you. And I will take his advice for sure when we bring up our next speaker. So thank you, Mr. Brick. So our next speaker today is Amy Rubino, who is the SHIP Director for Anne Arundel County Department of Aging and Disabilities. So, Ms. Rubino, are you with us today?
Yes, I am. Can you see and hear me?
I can. So I'm gonna go on mute and stop my video.
Okay. All right. Well, thank you so much, Commissioner Bahrain. And
1 second, so
Oh.
I could get the update, the next interpreter up on the screen.
all right.
We're all set.
Okay, thank you. Thank you, Commissioner Bahrain and Secretary Beatty, and thanks to your staff for hosting this listening session. I'm focusing on SSDI and Medicare supplements, also known as Medigaps. My name again is Amy Rubino. I'm from the SHIP program. SHIP stands for the State Health Insurance Assistance Program, and it is a federally granted program. In Anne Arundel County, SHIP is run through the Anne Arundel County Department of Aging and Disabilities. SHIP provides free and unbiased Medicare counselings for people with Medicare. We're staffed by both paid staff and by volunteers. All staff and volunteers must pass rigorous training and certification to provide accurate Medicare-related counseling, including Medicare supplement counseling. And I've had the good fortune of working with members of your staff during my 20+ years tenure here at Anne Arundel County SHIP program, and it's good to see some old friends on this listening session. I would like to commend the Maryland Insurance Administration's effort to ensure people under age 65 with Medicare have certain rights to purchase Medigaps. And I appreciate your attention to the discussion to promote enhancements to protect people under age 65 with disabilities. And I'd like to take the opportunity today to discuss two important issues that impact people under 65 regarding Medigaps. The first is the current eclipse of the 6-month guaranteed issue rights, their initial enrollment period, that people have had by remaining on Medicaid under the COVID emergency regulations and have, without any knowledge, exhausted their 6-month IEP guaranteed issue rights for Medigap. And the second point will be the affordability of Medigap plans for folks under 65. Before I begin this discussion, the under 65 market is a very diverse population. However, I'd like to highlight a certain population that I call critical clients that require a Medigap. Without a Medigap, these clients cannot access the care they need to stay alive. Specifically, I want you to keep in mind the clients who are disabled and require dialysis. I want you to keep in mind clients who are facing expensive chemotherapeutic treatments or radiation treatments for diseases such as cancer. And I want you to keep in mind clients who are in need of an organ transplant. Without a Medigap, their only option is going to be Original Medicare or a Medicare Advantage plan. Both of these options have very high copays for expensive care. Medicare Advantage plans often have the same 20% copay for care that mirrors the 20% copay under Original Medicare. People with these illnesses we discussed are not served by enrolling into a Medicare Advantage plan that requires them to pay 20% for their dialysis, that require them to pay 20% for their expensive chemotherapeutic treatments or radiation treatments. Prospective organ transplant patients are told they must have a Medigap in order to be considered for a transplant. And furthermore, they must maintain a Medigap to pay for the lifelong 20% copays for their immunosuppressants that ensured a transplanted organ does not reject. These clients are desperate for Medigap coverage to pay for these life-saving treatments. So let's kind of focus in on the issue at hand. Going to back up a little bit pre-COVID. Under the Affordable Care Act, people enrolled in the Medicaid expansion became ineligible for Medicaid when they became Medicare eligible. In March of 2020, the federal public health state of emergency suspended these ACA rules prohibiting continuation of Medicaid for when a person becomes Medicare eligible. People with Medicare retain their ACA Medicaid in a seamless manner. This retention of Medicaid has been a wonderful protection during this unprecedented and very challenging time. However, unforeseen consequences have been lurking. Recall, it is illegal to sell a Medigap to a person with Medicaid. People under 65 enrolling into Medicare Part B only have a 6-month guaranteed issue window to elect either Medigap Plan A or D without medical underwriting. People under 65 with a disability, by definition, have a medical condition that's going to preclude them with medical underwriting. As of November 2021, 21 months have passed since the onset of the public health state of emergency. People maintaining Medicaid during this state of emergency have lost their 6-month guaranteed issue right for Medigap. Every month going forward adds more and more people to the pool of persons who have exhausted their guaranteed issue right protections. Thousands of Marylanders, both over age 65 and under age 65, are currently in this predicament, and the numbers keep growing. These people have lost their guaranteed issue rights due to no fault of their own. Now, this is not just a state issue. So I implore you to work collectively with the National Association of Insurance Commissioners and the Centers for Medicare and Medicaid Solutions to create a solution nationally. Please formulate a solution for all people with Medicare, both over and under age 65, to ensure they have the right to purchase a Medigap without medical underwriting if they were affected by the federal COVID state of emergency. Now, while this is a national issue, is it prudent to sit and wait for a national solution? As Marylanders, we need to take actions to protect those needing a guaranteed issue for Medigap. I ask you, is a solution possible at the state level? Could a legislative solution be crafted, proposed, and passed during the upcoming 2022 legislative session that can ensure Marylanders have their guarantee rights preserved? I was just recently informed that the Medicaid termination for this population has been extended from January 2022 now to April of 2022. So the dates are becoming workable to craft a legislative solution in this upcoming legislative session to protect these very critical cases. I'm optimistic that a solution is at hand, and at the state level, I ask you to consider how best to make this happen. Thank you for your efforts to ensure people are able to afford their life-saving treatments by having by offering them these Medicare rights. Now to my second point, and that's going to be the cost of premiums. We want folks to have access to Medigaps, but we also want them to be able to afford the Medigaps. The issue with Medigaps for the under 65 market, the premiums, is a monumental barrier to coverage. In Maryland, a person under age 65 has the right to purchase Medigap Plan A or D. A subset could purchase a Medigap C, again, providing they apply within their 6 months of Medicare Part B enrollment to avoid medical underwriting. Now, the math is scary. The numbers don't equate to affordable insurance. Social Security states the average SSDI check is about $1,462 a month. In Maryland, Medigap Plan A averages $236 a month. The more comprehensive Medigap Plan D averages $570 a month. The Medigap Plan D is unaffordable, so it kind of is a moot option. However, the Medigap Plan A has been the only semi-feasible option for those critical clients we discussed, those that need a Medigap to pay for life-sustaining health care. As a side note, let's not overlook A more common situation, an SSDI client who simply prefers a Medigap to have the flexibility to see the providers of their choice. So going back to the map, in 10 years, a Medigap Plan A rates have increased by approximately 66%. The average SSDI check has only increased by 30%. Now, Maryland, we have laws to control premium prices. As you're aware, Maryland law caps the rate for Medigap Plan A at a rate no higher than the premiums paid by all policyholders age 65 and older covered by that Medigap Plan A. Plan Ds, Medigap Plan Ds do not have the statutory limiting amount. So the challenge, and this is a huge challenge, is how to ensure affordability of Medigap rates for both the under 65 market while also ensuring affordability for people over under age 65. So both under and over, keeping those prices affordable. I realize this is a topic that is not new to you, as you are charged with actuarially reviewing any and all premium rate increases. I know you wrestle with ensuring affordability of a product within the constraints of a, generally speaking, for-profit insurance market. But what puzzles me is Medicare is paying 80% of the Medicare approved charges, Medigap only 20%. You couple that with Medicare setting limiting charges for services. And finally, Medicare payment rates to providers has not increased proportional to the premium rates for Medigaps. I wonder what is the driving factor for the escalation of premium costs for the under 65 market. And I question what can be done to control the escalation of premium rates to ensure the affordability for folks who have SSDI Medicare. Is it possible to keep the premium escalations parallel to the COLA increases with the SSDI payments? I look for ways that SHIP and Maryland Insurance Administration can continue a dialogue on creative ways to help make Medigap plans an affordable option to all Marylanders. Thank you for your time. Thank you for listening to what's very near and dear to me, my concern over the first point, the loss of the guaranteed issue because of the COVID public health state of emergency, and finally, the affordability of Medigap plans. Thank you.
Thank you. Thank you very much for those comments. I am, as you were no doubt aware, while the state of emergency in Maryland was in effect, we were able to address that issue and to have companies suspend I'm sorry that my lighting has gone a little wacky here. But since the state of emergency has ended, our emergency powers are no longer valid. And we cannot require companies to take that action. We have, however, asked them to take that action, and many have responded. So what I would suggest to you and other advocates is to work with your clients to make sure that they shop with companies, because there are large players in the Medigap market that are allowing to treating that as an open enrollment period and are not performing underwriting. So, and we are always happy to work with and probably have some good ideas with what we might be able to do at a state level. And you can be very assured that this conversation is occurring at the NAIC. I, along with members of my team, sit on the B committee, which is the committee that looks at health and managed care. And this is something that's very uppermost in the mind of the committee and our conversations with the federal government and CMS. So thank you for underscoring that. And please rest assured that your words are heard and that these are things that we are doing everything we can do to try to address.
Thank you so much. I really sincerely appreciate that. Thank you.
We're going to take a short break and change interpreters.
Thank you. When we come back, we will have Jennifer Hall with us. Let me now introduce Jennifer Hall, who is the SHIP SMP coordinator for Queen Anne County Department of Community Services. Ms. Hall, welcome.
Commissioner Jennifer Hall seems to have dropped out. So we'll see if she comes back.
Okay, my apologies. Well, in that event, let's move on to our next speaker, and that would be, we have a pre-recorded video from Dr. Stuart Barron, who is a fellow of the American Psychiatric Association and is representing the National Alliance on Mental Illness for Maryland. Moira Cyphers, who is a principal of Compass Government Relations, is also on the call to answer any questions on behalf of the Alliance. So I will leave that to you, Craig and Tori, to play Dr. Barron's.
Good afternoon. My name is Stuart Barron. I'm a child and adolescent psychiatrist in private practice in Lutherville, Maryland. I also have an appointment as a part-time assistant professor in child psychiatry at Johns Hopkins University and am clinical assistant professor at the University of Maryland School of Medicine in departments of psychiatry. Thank you to the Maryland Insurance Administration for having this hearing to learn more from the disability community and for accepting this video for consideration. I would like to thank also the Maryland Insurance Administration and the offices of Mrs. Shelley Hedelman, Senator of my district, for having a meeting with me earlier to discuss the concerns that I was having in obtaining prior authorization for medications for my chronically mentally ill and disabled patients. Mental illness is truly a disabling condition and is therefore a mental disability. While for some the disability is time limited and afterwards they can go about their lives, for many, many others, it is a chronic condition requiring lifelong care, and the illness itself can interfere with all aspects of a person's life, including their social, emotional, medical, education, occupational, and religious well-being. Often, mental illness is a disability that not only affects the individual, but the families, friends, and the systems that the individual is involved with. Now, people with developmental, physical, and cognitive disabilities often have a co-occurring mental illness. In my field, I see many children with autism or other developmental disabilities who have a significant mental health disability. Now, mental health treatment requires care that cuts across several healthcare disciplines, and health insurances that you regulate are dependent upon to cover the myriad of costs associated with their care. As you probably know, private insurance does not adequately cover the costs of these services. In fact, from my understanding, public insurance may cover mental illness better than many private insurers, as long as you can find a provider. As a clinician, I will counsel my patients with severe chronic mental illness to apply for disability where appropriate, not for the stipend they will receive, but because the insurance they will receive from the government will support them in getting treatment for their illness without bankrupting their families. As you know, one of the leading causes of bankruptcies in this country is due to medical bills that are incurred for the cost of treatment. Some of the issues that I would like to highlight as a clinician that my patients run into are lack of access to treatment, inpatient hospitalizations and partial hospitalizations, otherwise known as day hospitals. They are few and far between, as was indicated in a front page story in the Baltimore Sun last week that highlighted the lack of inpatient beds for those incarcerated that have mental illness. In the private sector and in the public sector, there is a lack of beds for treatment for those that are seeking care. my understanding is part of that lack of beds is due to the poor reimbursement rates that hospitals receive for inpatient or partial hospital care. And therefore, there are a lack of beds for those that are acutely ill. And this was highlighted during COVID, where people could not get access to care, certainly in part due to the restrictions based on COVID, but due to the increase in mental illness and suffering requiring more institutional care. Now, as a result, my patients who are referred to the hospital, and many of your patients or loved ones referred to the hospital for psychiatric admission, will be in an emergency room for up to a week. Actually, autistic patients may be longer than a week waiting for a bed because they need more specialized care. Now, organizations such as Shepherd Pratt, thankfully, have come up with a crisis walk-in center that helps the psychiatric patient, in many cases, avoid the emergency room. But in very severe cases, which are many, they will end up there in the emergency room. And of course, waiting in the emergency room, the patient will not really get any care except for what has already been established, and will cause a risk not only to themselves, but to the staff, families, etc. You can imagine this is a terrible situation. Now, for patients that do get into the hospital, many times the hospitalization is too short because in order to get insurances to pay for the visit or the hospitalization or day hospital, the person has to evidence life-threatening behavior or statements for them to stay there, or a medicine has to be changed or some other obvious change in care from day to day. The problem with that is that our medicines and treatments take days, if not weeks, to show benefit. And so oftentimes a patient can be discharged from a hospital without being fully treated. And then, of course, they're either a risk to themselves, their families, and then have to be re-hospitalized. Now, can you imagine if you had a heart attack or a stroke and you go to the emergency room and are left there, not treated, and told, well, you have to wait 3 to 4 to 5 days for a hospital bed, so we'll just kind of warehouse you here, make sure you don't die, but we can't really treat you. Well, I don't think anybody would really care for that, and probably there would be a hue and cry to get people with these kind of illnesses in treatment. But for the mentally ill, they can stay there, and everybody knows it's a problem, but no one can seem to do anything about it. Again, back to insurances, I think we have to look at the rates that the insurances are willing to cover so that our hospitals can become viable or, treatment centers. You know, during COVID, there was, amongst many other things, terrible stories about ICU beds that were full and at capacity. That is indeed terrible. Well, if somebody suffers from a psychiatric emergency, a brain illness, that's an emergency situation, and a hospital bed can be the equivalent of an ICU treating a heart patient or a stroke patient. But again, mental illness, in part due to the stigma, lack of coverage, this situation goes on and on. Now, of course, the causes are many, not only with insurance, but I do believe it plays a very significant part. Now, let's go to the outpatient, where many people are trying to receive care. Now, again, for the person that has a mental illness that is short, prescribed, has a beginning and an end, is not chronic, the insurance will probably cover reasonably well, though still with difficulty. But for the more chronically mentally ill, not just those with schizophrenia or bipolar, but depression, ADHD, anxiety, OCD, PTSD. Insurances really are not adequate in many cases. First of all, the reimbursement rates that an outpatient clinician can get, I believe in Maryland, are quite low, which then incentivizes people to become out-of-network providers, further lessening the access to care for in-network doctors. The lists that insurance companies maintain are not always adequate or correct. My patients sometimes, in trying to find an in-network doctor, will have to call 15, 20 people only to be told that the agency no longer accepts their insurance, or that no one is available to take their care. And so this causes a lot of angst and, of course, deterioration in a person's psychiatric status. Now, if they can find a clinician in their network, the deductibles can be very high, as we all know, not only for psychiatric illness, but medical illness. And this also can cause problems in accessing care. If someone has to go out of network, the out-of-network deductible is so high that they probably will never see any money from the treatment that they obtain. One very popular program in the healthcare exchange, the Care First, Blue Cross, HMO, you can't get any coverage for an out-of-network clinician, and yet the cost is fairly high for such coverage. Now, let's talk about medications. Sure, there are some good generic psychiatric medicines today, and many times those are covered without incident, and that's very good. But in my patients that have chronic debilitating mental illness, and not just mine, but many patients, medicines can be very hard to get authorized. Oftentimes, people's insurance may change from year to year, so the formularies change from year to year, and then the formularies within the companies themselves, the programs can change from year to year. Now, I understand cost containment. Everybody can't have everything they want. But in cases with patients that have chronic long-term illnesses, where they have been on medicines year in and year out, the same medicines, often crafted after hours and years sometimes by the physician trying to craft their medication strategy, the insurance develops an amnesia every year and says, well, you have to prior authorize it again. When clearly you can see, if the insurance company cared to look, you could see that the patient has been on the same medicine for years. And medicines are not interchangeable, even though they are FDA approved for the same condition. There are differences in the medications. And unfortunately, the prior authorization process is really not very smooth. Yes, there is a computer app that we can, request, and in many cases that works. I believe it's Cover My Meds. But many times I prescribe a medication for a patient. They've been on it for years. It's just happened this past weekend, where my patient was on a Daytrana Ritalin patch for years. The mother goes in, as often is the case. Life happens. Life is very busy for people. They have one patch left. They go to the pharmacy. I got the prescription in Friday afternoon. I got a call Saturday that she had to pay $400 for it because the insurance required authorization. Now, I did get the authorization tape. In fact, I'm doing this tape tonight because all day today I've been doing prior authorizations for my patients, many of whom have been on medicines for years. But the clock ran out and I have to do it again. Now, what I don't understand is why there can't be a bridge prescription. One patient of mine that has Medicare was told that the medicine will need to be prior authorized, but they will be given a month bridge. That was very helpful. I was able to incorporate in my day, get the prior authorization. Everybody got their medicine. Everybody's happy. But with the current situation, in fact, I must say, the healthcare exchange plans through care that is managed by CVS Caremark for Care First is probably one of the ones that I struggle with a lot in my practice, that when I do a prior authorization, the computer app works maybe 75% of the time. Then I have to call somebody. The person at the other end of the phone is just a data taker. They have no clue what they're asking. They're just reading off a script. It takes 20 minutes of my day. And in the end, if it's not authorized, then it has to go for prior authorization. Now, if I have to speak to a physician to discuss my case, many times they're not board certified child and adolescent psychiatrists. I don't think that's right, or a psychiatrist for that matter. And then for me to schedule my busy day, I have to wait for them to call. Maybe I'll be available, maybe I won't. But in today's world with technology, there should be a place where I can go online and schedule an appointment. And by the way, there are rarely after hours times where I can speak to somebody that has decision-making power if the company feels the medicine is not appropriate. So this setup is not really meant to get appropriate care. It's really more a bottleneck. And I would suggest that there are many options that one could do to make this process smoother. Now, thankfully, the Maryland Insurance Administration has been helpful for me when I've been denied. I've faxed over my letter, and in almost all cases, they were able to get it overturned. But why, when a medicine is medically necessary and I present that, the insurance company only says it's medically necessary when the Maryland Insurance Administration gets on their case? That's not right, though I really appreciate your help. In summary, or excuse me, in my final remark would be the following. By the percentages, either some of you may have a mental illness, or certainly people you love or are friendly with have a mental illness. Ask them what it's like, if they'll share, to get care if they're not on public insurance, which, by the way, is probably easier. You know, there was a time where my kids could only get into Johns Hopkins psychiatric unit if they have medical assistance, but not private insurance. Now that's different, but why was that? Not because of Johns Hopkins, because the insurances didn't pay what needed to be paid for the kids to be there. In fact, you might even try, as if you have a mental illness, to try to get care through your insurance. And you'll see how tough it is. I want to thank you very much for listening. I want to thank those that are advocating for those with disabilities. Thank you for your work. And I really thank my patients, because without them, I wouldn't have a job. But with them, I can try to make their lives better. And that's really what it's all about, is trying to help our patients get better and manage and live the lives that they can. Thank you so much.
Thank you. Do you want to take a minute and switch when to see if Miss Cyphers?
Yes, we'll take a second and switch interpreters.
Great, thank you. So I know, Ms. Cyphers, you're available if there are any questions. I don't know if anyone from the MIA or Secretary Beatty has any questions. I can tell you that this is an issue that obviously the MIA is very passionate about and concerned about. It's a big part of what fuels our network adequacy considerations. And obviously we are in the midst of developing reporting requirements for MAPIA. So we take these remarks and these considerations very, very carefully. And, you know, many of you know my own background, having worked myself at Shepherd Pratt and having, you know, mental health issues very foremost in my mind, at least from an insurance perspective. And I know how frustrating it is having, for my own family members, tried very, very, very hard with much frustration and difficulty to try to find treatment. And that did not happen to be an insurance issue. It happened to be a provider availability issue. But there are, I know, frustrations within the insurance system as well. So your words are much appreciated and you are heard. And I don't know if there's anything else that you want to add to Dr. Barron's presentation.
No, thank you so much. We really appreciate you making mental illness a part of this discussion because there is so much overlap. And, we know MIA has really been getting down in the trenches on parity for the last few years. So grateful for that. And thank you for permitting Dr. Varon to submit his video rather than be here live today. I know that he wanted to try and make it work, but insurance carrier accountability is first and foremost in our minds, and it kind of all goes together with network adequacy and ensuring that we can take care of, I think, the 300,000 Marylanders who are in the public behavioral health system and the many more, I think about 1 in 5 who experience mental illness over their lifetime. So thank you again, Commissioner Breen and Secretary Beatty.
Yeah. Craig, did we regain Ms. Hall?
No, I'm not seeing her in the list of panelists.
Well, in that event, I want to thank all of our invited speakers for their presentations. They were extremely helpful, very, very important content and so much context and humanizing, the issues. It's we can get our heads up in a cloud and talk about things conceptually, but it's really important to hear stories and to understand what the impacts are on the lives of individual human beings. So I want to thank all of our speakers for helping us with that. We are now going to turn to our registered speakers, so individuals who asked to present today, and we're very happy to have each one of them with us. If you did not sign up to speak, but you are online and you would like to be heard today, just note that in the chat function and we will arrange to bring you over after our registered speakers have concluded so that we can hear from you. And with that, I'm going to start with Dr. Marvin Leventer, who is a dentist, anesthesiologist, and a general dentist at the University of Maryland Medical Center and a faculty member at the University of Maryland Dental School. Dr. Leventer, I hope I pronounced that correctly. Welcome. Very happy to have you with us today.
Thank you so much, Commissioner Bahrain and Secretary Beatty. I come to this presentation as a clinician. I've been in private practice for about 30 years or so. And sort of at this point in my career, mostly, I think I'm taking care of a lot of Dr. Varon's patients that have a lot of I have patients with a lot of mental health disabilities, but also, we see the combative patients, the self-injurious patients, the patients with PTSD or CP or Down syndrome, and probably about 20 other syndromes that they can't be treated in a dental office. They can't be treated in a clinic. They can't even be sedated the way people would think of, like with a little bit of Valium or nitrous oxide. These are the patients that need to be asleep, like general anesthesia, to have their dental work done. And I'm one of the few providers, I guess, in the state, really, where these people can go, where these patients can go. They come to us at the University of Maryland because nobody else will see them. They come from Western Maryland, the Eastern Shore, Southern Maryland. Some of them come from out of state. They've been to maybe 10 other dentists, is not uncommon, because the parents or caregivers they're like trying to get them care and they're doing their due diligence and doing whatever they can, and nobody else can take care of these patients. So we've created, Dr. Tinenoff and the Insurance Administration way back when had created sort of guidelines for the under 21 group where they had reasonable reimbursement for, let's say, dental fees or anesthesia fees or getting them into an operating room. But what happens is these kids get older and they turn 21, and then their medical assistants, which is what most of them have as dental insurance,
Mommy, Daddy, you're under arrest.
Because they don't have a job, so they can't get job insurance. They're over 26, so they can't get insurance from their parents. They're not 65, so they can't get Medicare. So where do they go? They take whatever the state will give them, which is really let's just say it's inadequate. So they come to us for care, and let's say I can put some of them to sleep in a office dental school environment, but some of them are just really too sick. So the only place for them to go is the hospital. And then we get patients that are referred from other hospitals to us at University of Maryland because we're a tertiary care center and we can take care of the sickest of the sick. And we have a reasonable dental component. So like, why don't other hospitals have a dental component? Well, part of it is reimbursement, because if you look at getting patients approved for, let's say, a $10,000 or $15,000 facility fee, it's not really so easy. And if you look at the professional fee reimbursement, whether it's anesthesia or the professional fees for, let's say, the dental care, it doesn't compare to orthopedics or GI, ophthalmology, spine surgery. So hospitals aren't making any money. So they really don't want our cases. There's really no impetus for them to say, hey, these patients are the sickest of the sick, the most vulnerable in our population, and we should really help them. But they don't want that because they've got to, take care of the bottom line and make enough money to pay everybody. Like, we understand that this is the way the world works. Everything is about money. We all understand. We all understand that. So where do these patients go? What do they do? So they come to me, and I don't know, I probably have a list now of about 50 patients that need to be seen in the operating room for dental care. It's really probably more than that. That's a sort of an underestimate. And like, the hospitals aren't going to give me, block time every week to go see patients because it's a money loser. So if I get, I can see a couple of patients a month, I'm never really going to get caught up because more patients are going to keep coming to me. And then the care goes from elective care to acute care. So now something that turned out to be, let's say, 10 or 15 or 20 fillings on a kid, with CP or Down syndrome or whatever it is. Now I've got to remove half their teeth because it's gone so long and they couldn't find anywhere to go or they had to wait. So now, we have to partially edentulate a whole bunch of people, which is not really, let's say it's not the ideal. It does get rid of infection though sometimes. So they wait around until the problem gets like worse and worse and worse. And then you end up with these people in your emergency rooms, which just cost like, it's a ridiculous amount of money that costs. So you say, well, what's the answer? So I think it has to be increased reimbursement for professional fees. It has to be less, what's the word? They're for approving patients for a hospital, getting patients approved for the hospital, that the facility fee would be paid has to be a whole lot easier. Like, the amount of patients that just walk away after so much time, it's like, well, we can book you in the hospital, but we have to get it approved. And your insurance company doesn't want to pay the $12,000 and the dental fee isn't covered and they can't afford that. So like, where do they go? What do they do? They end up in this black hole. Literally, it's a black hole. And we get frustrated as the providers of care. And I'm not even the money person. The people that try to organize the sort of payment and the insurance and the pre-authorization, they're frustrated beyond belief. It's like, these patients need care. Like, this is disease. But, again, because it's, it's dentistry, well, it's just teeth, it's not that important, which we all know is, I won't even say what I think. So, what's the answer? Do you take adult patients that are over 21 and under 65 and just give them Medicare? Because if you have Medicare, like, they're going to pay the fee. It's going to be a lower fee for the facility fee. But then I'll get patients that come in that, let's say, they're approved, their insurance will approve them for, to like take a tooth out, but not necessarily to fix a tooth, where you can only take out so many teeth, or you can only use so many materials. So, and like, if you think about these patients, let's say, going to the operating room and getting dental care, like, there's no plan. Like, you can't even look in their mouth before you start. Like, there's no way. Like, you can't take x-rays, you can't do anything. So the patients show up, they go to sleep, which is usually a really big deal. It's very complicated. It's very serious. There's a lot of risk because these are the sickest of the sickest patients. And I, commend my colleagues at the University of Maryland because they do a really, really good job. And then we take x-rays, we look in their mouth, and this is like a 3 or 4 hour case or so, like average. And we figure out what we need to do and then we do it. And you can't just say, well, I only have a couple hours, so we'll do as much as we can, and then you come back and we'll finish. Because no insurance company is going to reapprove another $15,000 facility fee in a in a year or 6 months time. It's not going to happen. And let's say the Medicaid reimbursement for anesthesia goes to an hour and a half. That's it, and then it cuts off. It doesn't even pay for the cost of care. Like, you're losing money. So like anesthesia sees us because we're a big university institution, and they do the right thing and what they have to do. But if you're looking towards like other hospitals or private practice, it's like, okay, you gotta quit after an hour and a half because you're not gonna get paid anymore. And if you want to be able to like pay your staff and the services and the materials, it's never gonna happen. So there's this just multitude of layers and layers and steps that make it like more difficult and more difficult. And I have like kids, adults have to like take out all their teeth because it's just, it's so bad. So I guess in summation, because I could just go on forever and I probably shouldn't really do that. It's a problem. And we need more reimbursement. We need the Maryland Insurance, Administration to look at this carefully and, take some time and effort and say, this is really, a place where we should be putting our money because, what's the risk, right? What if we continue the way we're going? If you all remember, 20 years ago, the risk and, you think about M&M morbidity and mortality related to uncontrolled disease, this is a cluster waiting to happen, and it's happening before our eyes. So I appreciate you allowing me to speak and, take some of your time. And I implore you, I guess is really the right word, to look at this carefully and make it and help us make it better for our patients with disabilities. Thank you.
Thank you, Doctor. I appreciate your comments. The Insurance Administration is not a rate-setting body for providers, and nor are there, rules in the state outside of the sort of the hospital all-payer system. However, I think part of the power of these listening sessions is our ability to provide information to policymakers and decision makers, and highlight and elevate the profile of certain issues. I think that one of the things that we could certainly do is talk a little bit offline about dental care and maybe break this down a little bit more in terms of some of the more general concerns and problems versus those that are perhaps more targeted with respect to or unique to people with disabilities. And so maybe begin to tease out some of those details. So I
would love that.
With you offline and have some of that conversation. So
Madam Commissioner, I also wanted to say, I'm sorry, I can't start and stop my video, but I would also like to say that we would love to be included in those discussions.
Yeah, absolutely. We'll set something up to talk about what's going on. And, you're right. I mean, we don't think about dental care, and yet dental issues are so critical to overall health and can often be, indicators and frankly causes of other conditions. So
yeah,
we'll set that up.
Thank you.
So thank you very much. It looks like we're going to have an interpreter change, and then I will hear from Ms. I'm assuming it's Shea Newman. I hope I got the first name pronounced correctly. We'll just take a second and switch now.
Hello, my name is Shea Newman.
Sorry.
I just have a few points as a parent of a deaf and hard of hearing child that I would love to see improve for the Maryland Medicaid and medical insurance as a whole. One issue is lately, there's been a delay when it comes to getting new ear molds. And I think it possibly is the communication between authorization. When you have a young child, this can affect their access to hearing if the ear molds are delayed, or for a very young child, by the time they get the ear molds, they have grown out of them. The other thing that I would want to make a recommendation is the Medicaid insurance provides speech therapy for children who can hear or are trying to rehabilitate their speech. But is there a way also you can have some kind of communication or speech component for children who have language deprivation in ASL, whereas they can go to an outside quote unquote therapist? I don't know if that's a speech therapist or some kind of communication therapist, where you can work with that child to build up their communication skills in ASL and their language skills so they can do a little bit better. And lastly, to piggyback off the hearing molds, or it's just, I think the delay is with hearing apparatuses, period, meaning hearing aids or CI components. Sometimes when the pre-authorization is delayed, one time I think when my son had to get a new device, it took months. And sometimes when you don't have the equipment or the equipment's not working and you need new equipment, that leaves the child without access to sound. Those are my comments. Thank you.
Thank you very much. I appreciate that very much. And we will, one of the things that I want to do is circle back, with our team. And if it's okay with you, do we have your contact information?
We have her email.
Okay.
Yes, they've sent me an email, yes.
Yeah, we may reach out for some more details, particularly with what you've described about the molds. So thank you for bringing those things to our attention.
Yeah, it just recently happened in the last couple of years. Before, I don't know if it's, I don't know. I'll say their name. Children's Hospital has changed their methodology or who they work with. When he was younger, it was on the money. Now we had an appointment in September. This is now November. I haven't gotten a call that his ear molds are ready. So I think before they can even order it, they have to get authorization. And then you have to wait for the manufacture time. So it gets to the point where it's like, luckily my son is old enough that he's not growing like he was when he was 2 and 3 years old, when the ears grow like crazy. But if the old ear mold is not fitting properly, now we may have lost 2 or 3 or 4 months and he's wearing an improperly fitted ear mold.
No, I appreciate that. I mean, obviously we regulate the insurance component of this, but again, we're often able to be a source of information and to pass information that we hear on to others, including frankly, insurance companies that want to be informed about these delays as well. So thank you very much. And let me now see if we have on the line, I don't think we've seen Gwendolyn Benton. Is Miss Benton here? Okay.
I'm not seeing her.
Excuse me?
I'm not seeing her, yes.
I didn't think so. So I think we'll move on to our next pre-registered speaker is Denek Burton.
Hello. Hi. I wanted to speak on, I lived in the District of Columbia. I've been on Medicare since 2012. I lived in the District of Columbia until 2018. And then I moved to Maryland. And District of Columbia, I believe it's called QMB, paid my Medicare premium and was a secondary insurance to my Medicare because I was totally disabled. When I moved to Maryland, I was just barely over the income limit. And then when I was reading further about the policy and procedures, it says they're supposed to take off a percentage of your housing. If your housing, I believe, is over 50% of your disability payment, but nobody seemed to understand how that worked or what to do. So I was denied Medicaid because I have Medicare. And that $149 coming out of a total monthly income is a lot of money. And I don't know if it was just they didn't know what they were doing, or is there a policy or plan in place to help with the premiums of Medicare in the state of Maryland? Particularly, I'm in Prince George's County.
Commissioner, this is Joy. And if you would like, I'll have one of my staff reach out to this young lady and we can see what we can do to get her some assistance.
Boy, you read my mind. I was going to say, my answer is honestly that I don't know. But what I do know is that Joy's team will dig in and help you find a resource, help you find the answers.
Okay, I appreciate it, because when you go through Maryland Health Connect, immediately if you're an adult and you say you have another health insurance, including Medicare, it automatically denies you Medicaid.
Right. But Joy is the Associate Commissioner for our Consumer Education and Advocacy Program. And so she will be able to take information and just help you navigate.
Okay, so will she have access to my email address?
Yes, I do. And
Okay.
the person
Okay.
that'll be reaching out to you is Patricia Dorn. And she probably will not be able to reach out to you until tomorrow, but we will be in touch.
I appreciate it very much, because it's very hard to have a child on a monthly fixed income. And it may not seem like a lot to someone else, but $140 some coming out of my only income per month, creates a problem. So I appreciate it. Thank you.
No, Ms. Burton, literally, this is what we're here to do. This is what we're here to do. So if we can help you, we are very, very happy to do it. And that is a lot of money. So thank you for reaching out and letting us know what the concerns are and how we can help you.
Okay, thank you.
Our next scheduled speaker is Janice Fencic. So if Ms. Fencic is on the line.
Not seeing her name listed.
And the next registered speaker is Mohammed Agabian, and I apologize if I mispronounced that. I think we saw this gentleman online earlier, and I know you've been in the chat room. So if you want to unmute yourself, we're happy to hear from you. And Craig, if he's having problems, can we help him?
You're muted, Mr. Agaban.
Get him, practice or whatever, and then he'll go back to playing games. And, it's getting cold out here.
Hey. 50 days when I don't even.
Mr.
Agaban? Oh, that you're finished. Okay.
Hello, how are you? We can hear you.
I'm good. How are you?
Oh.
Good tonight. Those are young girls. What the man? They look like middle school kids, don't they?
Practicing cheerleading.
Mr. Agaban, would it be easier for you if we were to talk on the 12th?
All of a sudden, last week I had kidney stones. Now I'm having. What?
Yeah.
We're not able to hear you. We're happy to hear what you have to say, or if it's easier for you, we could have a conversation, a visit or a telephone call, if that would work better for you, but we're happy to hear anything you have to say to us today.
Let me put your stuff away, wash your arm, man.
I think that maybe the best way to do this is we have your contact information. Can we get in touch with you? And maybe try to interact that way. Craig, do you have contact information for him?
I do.
So I would invite you to make any comments in the chat room like you did before. And then otherwise, if any of the staff there can speak for you, that's okay too. Otherwise, we'll make arrangements to hear from you. Is that okay?
Yeah.
All right. Thank you very much. So Craig, why don't we, there you go. And then if we could, okay, so our next registered speaker was Jane Bellmeyer, who unfortunately had an issue come up at her work and was not able to join us today, but she did provide a written statement, and I'm going to read that written statement now. And in the meantime, anyone who wants to speak but didn't register to speak, just please indicate that in the chat room, and we will reach out to you. Having a little bit of a mouse issue here, so get to Ms. All right. So this is from Ms. Bellmeyer. My name is Jane Bellmeyer. I am a 62-year-old tax-paying voting Maryland resident who is hearing impaired. I have worn hearing aids since I was 19. Over the years, my loss has gone from moderate to severe to profound. 10 years ago, I was told my loss is 85% in each ear. I am a reporter by trade. It's what I have done all my adult life, first in radio and now in print journalism. Both fields require a lot of listening. Imagine having to do this job with only 15% of my hearing. It can't be done. When my children were still under my roof, I was eligible for help from the state's various disability funding sources. Now I am forced to pay the entire bill on my own. My insurance does not cover any of it past the initial hearing exam. This, in my opinion, is blatant discrimination against the 1.3 million Maryland residents living with some degree of hearing loss. What I suspect people fail to realize is hearing aids are not like eyeglasses, which most insurance will pay to replace every 2 years. From a reputable audiologist, a good set of hearing aids will last as long as 10 years. This is because the audiologist will prescribe a model that can be tweaked internally if and when the person's hearing decreases or the range of loss changes. My previous set of hearing aids lasted nearly 10 years. When I replaced them 2 years ago, I had to get a loan for the $4,000. Because it is a medical device, I did not have to pay sales tax. Did you get that? It's a medical device, according to the Internal Revenue Service. The batteries I require to power the hearing aids are also tax-free because the IRS deems them a medical device. What is the insurance industry afraid of? Why do they routinely fail to offer coverage for hearing aids? My health insurance through my employer will cover a wide range of needs, including any number of elective procedures. I elect to be able to hear. We need to do better, Maryland. In this age of trying to address all the inequities in society, how about addressing the fact that many of the hearing impaired are in self-imposed isolation, unable to communicate, unable to work, unable to interact because of the simple fact that hearing aids are expensive and health insurance chooses to discriminate against us. During the 2021 Maryland General Assembly session, Delegate Mary Ann Lasanti introduced House Bill 910, which would have required all insurers writing policies for the state to cover $750 toward the cost of each hearing aid. Representatives from the Maryland Board of Audiologists testified that the minimum should be $1,400 per aid. The bill died in committee. Delegate Lasanti has told me we will try again in the 2022 session. In this age of equality, how about we help the 1.3 million Maryland residents whose only barrier is the inability to hear without assistance? Respectfully, Jane M. Bellmeyer. And we thank Ms. Bellmeyer for her comments and her input. And Craig, I will.
We need to take a break and switch interpreters one last time. And then we have another speaker who requested to speak. And the speaker is Heather Kangas. And she has been, okay.
Hi, Ms. Kangas, and welcome. I have been following you in the chat and happy to give you a few minutes today to share your thoughts.
Thank you. I've been very vocal in the chat. My name's Heather. I'm a licensed clinical social worker in Maryland. And I just wanted to kind of echo what the child and adolescent psychiatrist said previously. Super important. And I'm really glad to hear from folks working on the ground with patients and from patients themselves about these issues, because there are so many barriers to patients getting care. And for those of us working to help patients get care, helping them access care, I previously worked on an inpatient psychiatric unit, and I remember having to have a psychiatrist take time out of their day. They were covering both the inpatient psychiatric unit as well as an outpatient mental health clinic so that they could do a doc-to-doc with an insurance company regarding whether or not it was needed to keep a suicidal patient on our inpatient unit. And so they had to take like 30 minutes out of their day just to do that. And I feel like it just takes such valuable time out of our clinical, we could be doing other things. And even now, I don't do as much direct patient care anymore. But if I work in the emergency room and I have a patient that needs inpatient chemical dependency detox for alcohol or benzodiazepine abuse, that authorization process over the phone can take 30 to 40 minutes. And as the physician said, you're initially talking to somebody who doesn't have any credentials, who doesn't have clinical experience. And it kind of feels like it sort of feels like a waste of your time. Like we wouldn't be recommending admission for somebody for that if we didn't think it was necessary on our end. And so to have to go around and actually do that while we're working in an emergency department that's already flooded with a bunch of other patients with different needs, it just feels like we're being tasked with so many different things. And then we wonder why people are leaving healthcare. We wonder why we have providers leaving healthcare. It's because we're not just being asked to provide direct patient care. We're doing so much administrative work all the time and having to deal with insurance companies and these bureaucratic headaches, to be honest with you. And just lastly, I'll say, I think, the doctor who spoke talked about how Medicaid is often a lot better for, folks living with a chronic mental illness at accessing care. However, he mentioned there is a lot of lack of access, a lack of programs. And I will say some of what I've noticed in the child and adolescent psychiatry world recently, there's been an increase in need for eating disorder treatment throughout the pandemic. There's been articles written about that as well. And it's very hard to find providers who are not out of network, who take Medicaid, who provide treatment for adolescents and young adults with eating disorders. And many of the folks who actually do have very long waiting lists. And as he mentioned before, again, if you have a child or adolescent with a developmental disability or a child who might be on the spectrum who needs a further evaluation, and you don't have other resources to possibly pay for an evaluation out of pocket, you're going to be waiting like over 6 months because there's just not other options out there for folks who have Medicaid. So it is, I think, I do think insurance does play a part in this access issue. And so we do have so many folks who aren't getting the care that they need. And it's something I think that definitely needs to be discussed further. So I appreciate you giving us the time to discuss that today. Thank you.
Absolutely. And thanks for your comments as well. I know it is extremely frustrating, on the units. One other, I don't see anybody else who's asked to come over. Craig, do you see anyone?
No, I don't.
Can you hear me or no?
Yeah, there's someone on the phone. Yeah.
Yes, can you hear me?
Yes, we can hear you.
Okay, hi, I'm sorry, I'm not good at this kind of stuff. Janice Fencic, and if somebody can get back to me a little, unfortunately, I am a gang rape survivor at 13, and at 61, the only reason I'm alive is because my parents were loving geniuses. Lots of malpractice. It's sad, and I don't have much good things to say about the mental health system in Maryland. Okay.
Thank you very much, Ms. Fencic. Are you still there?
Yeah.
Janice, this is Kathleen.
I know you.
You know me, so.
You know who I love? I do business with Kaiser Permanente now. Love them.
So I have your contact information, and let's chat offline about specifics.
Sure.
All right, you take care, and thanks for your comments today.
You're welcome.
Craig, was there anybody else that asked to come over?
I am not seeing anyone else.
I have one other set of remarks that I have permission to read, but not associate the name. So let me just read these out loud. I have coverage under Care First as a primary insurance, as well as Medicaid as a secondary, and am finding it impossible to get mental health care. Many hospital systems, such as MedStar and Hopkins, would take my insurance if my appendix burst, but will not take Care First for mental health. They are the largest private insurer in Maryland, but I cannot get care through them. If I just had Medicaid, I could get care through these institutions. What is the problem with Care First? You can read my comments out loud to submit my name. So I am not sure what the answer to your question is about your specific situation or your, but if you want to reach out to, so I don't think we have your contact information. If you want to privately, instead of under hosts and panelists, you can send a private message to me or to Craig or to Joy with contact information. We'll try to follow up with you, if that's okay. I'll just wait to see that. And it looks as though we may have had one other person who would like to speak.
Yes, Commissioner, it looks like there's a Vicky Stoddard that would like to speak.
Okay, let's see if we can bring her over.
Okay. And we do have a message.
Okay. Okay.
Hello. Can you hear me okay?
Yes, we can hear you.
My name is Vicky Stocker, and I'm actually a nurse, an RN, but more importantly, I'm a mother of disabled twins. I'm 62 years old, and they were born early when I was only 24 weeks pregnant. So I have a lot of experience with healthcare needs and of disabled. They're both disabled. Both of them are blind, and one is blind with severe autism. During their lives, I worked full time, and I always had them on my insurance. And even when they transitioned over, when they were 21, I kept them on my insurance. It was very easy to keep them on till they were 26. And then I applied and got them on my insurance after they were 26, up until 3 years ago when I semi-retired and I'm on somebody else's insurance. So they are no longer on my insurance. I just wanted to comment on the challenges. I believe it has gotten a little bit better because I always had them on my HMO and then they would be on the Medicaid. I could see the difference between the two and how challenging it would have been back then to actually find good continuity of care, especially for specialists. It's a challenge now, even though I found good primary care, not that far away, but it's a little bit more of a distance that I would like. But it just is a challenge to find, if I need a specialist, right now I'm trying to find a good dermatologist just for a skin check. And if there is something that needs to be done, I'm actually not sure where I'm going to take my son. So just for even preventive care like that. And, you do give some choices. I forget how many choices there are, but a handful of choices. But I think each one has its own separate little idiosyncrasies about how far away a specialist is or what exactly they do. And sometimes when you call the insurance company and you look on the website and you find the particular specialist you're looking for and you call them up, only to find that no, they're not taking any new patients, even though it's listed that they are, or, oh, we shouldn't even be listed on there at all. I don't know why they keep us on there, to, oh, we're only taking 21 and under for this, so it's not even noted. So I do worry about them in the future. There goes my internet unstable again, so hopefully you can hear me. And so that's really all I want to say. I've always been able to really advocate strongly for them because of my medical background. But I worry about the others who don't have the background that I do. And it's just really critical that we find some way of keeping good providers in those particular healthcare plans so that they do have some choices like most other people do when they have insurance. And I think that's all I have to say. Thank you for listening.
Thank you for sharing with us today, your thoughts.
Can you comment to those points? I guess that's yes.
Well, I think we'll take.
Or is that somebody else?
I think we'll take comments offline. If you want to put your contact information, then I think we can address some of your individual concerns.
Okay, should I just put it in the chat?
Yeah, and if you want to, instead of the entire, universe of all hosts and participants, if you want to target Joy Hatchett or me or Craig, it'll all go to the same place.
Commissioner, would it be okay if Kirsten made a couple of comments?
Sure.
Regarding?
Absolutely, yes.
Okay,
Hi, this is Kirsten McGrath. I work for the Department of Disabilities. And I just wanted to kind of echo Vicky's points that I think continuity of care is also an issue, especially with individuals with disabilities moving from pediatric to primary adult care. A lot of the times we find that individuals with disabilities are staying with their pediatric providers for a lot longer than the typical patient, because there is no one at the adult level who has that specialty or focus. And so families don't feel like they have options in that sense as well to transition. And I think it just kind of echoes your point about, you kept them on their insurance because they had access. And now they're transitioning out and you're having difficulty finding specialists. So I know that that's a huge concern too. And in the state of Maryland, I think we need to put some focus on provider education surrounding these transitioned aged groups and specialty care of that nature. I think they do get some of it in their nursing school and medical school like breakouts, but I think more in-depth options would be important too. So that's all I wanted to say. That was me who commented. Can I make comments to those points? I apologize for any confusion.
No, not at all. Thank you. And I know that we have, we're going to switch interpreters. Okay. So no, it's a critical point. And, part of what these listening sessions do is they actually inform us of what issues are so that we can dig more deeply. So there are going to be things that we've heard in this session that we don't have an immediate response to. But what we will do is we'll go back, we'll look at it, we'll consider where the interface with insurance is. If there really isn't an interface with insurance and what we regulate, that doesn't mean that we'll just stop there, but we will pass it on to other state agencies or groups that are tasked with those concerns. So we're always very happy to hear the issues. Don't feel that we're ignoring them because I don't have an immediate response to them, because the whole purpose of the listening session is to have things brought to our attention that maybe we haven't focused quite as much on, or we haven't heard as many complaints about. So just wanted to clarify that. Craig, I don't know if there's anybody else who would like to be heard today.
No, Commissioner, I'm not seeing anyone else.
So I'll take a moment and then also offer Secretary Beatty the opportunity to wrap up a bit as well. But I want to thank all of our participants today. After each of these sessions, my team sits down and has detailed conversation, develops a set of action items that are based on what we've learned from the session. These action items usually include the development of targeted educational materials and presentation to assure that policyholders and providers know their rights and remedies, investigations into reported practices that are inconsistent with Maryland law, and communications with insurers about how to address specific consumer concerns. In December, we will be publishing our proposed list of topics for the 2022 listening sessions, and we invite anyone here today to share your ideas by sending an email to Mr. I, who's going to put his email up in the chat room. And so those will conclude my remarks, but Secretary Beatty, very happy to hear from you.
I just want to once again thank you, Commissioner Bahrain, and also members of your team for really shedding some light, allowing some time for discussion around this very important policy area, and especially as it relates to this very important community within the state of Maryland. And thank you to all the panelists and participants for bringing forward these important issues, which we will be working with the commissioner and her team on. So thanks again.
Thanks, everybody. And with that, I think we will call this a wrap, and we thank all of the participants and everybody who spoke today and shared their stories with us. Take care, be safe. Thank you.